Welcome to the closing plenary for the Global Health Symposium 2022. My name is Dr. Akudo Anyanwu, and I'm Vice President for Development at Texas Biomed. It's been my pleasure to host and interact and mingle with many of you over the course of the last 2 days. For our closing plenary, we have a number of distinguished panelists participating in this closing plenary. You all probably remember for the opening, we started off with talking about the linkages between public health and the economy. And that was strategic in centering public health and science within the context of the overall development of any economy, city, and to really show how important it is. We end this symposium really taking a critical look at our pandemic preparedness systems here in the US and globally. And that, again, is for strategic reasons, because we want to make sure that we're ready and we get it right, we learn the lessons. And so the panelists for today's closing ceremony, I'll start with the introductions. One person needs no introduction, our very own Mayor of San Antonio, Mayor Ron Nirenberg, Mayor of the City of San Antonio, the 7th largest population in the US and one of the nation's fastest growing cities. Please join me in welcoming our very own mayor. We also have as our panelist a gentleman that I have the privilege of calling my boss, Dr. Larry Schlesinger. He's the president and CEO of Texas Biomed, and a physician scientist in his own right. Welcome, Dr. Schlesinger. So on the screen, we have Dr. Olusoji Adeyi. He's president of Resilient Health Systems, which is a policy advisory firm. Soji has over 20 years at the World Bank as director for their health portfolio. And he is the author of Global Health in Practice, Investing Amidst Pandemics, Denial of Evidence, and Neodependency. Please join me in welcoming Soji. We have Daniel Thornton. Daniel is a senior advisor to Gavi and COVAX, the multilateral alliance funding vaccine distribution. And so they've played a huge role in the pandemic. Please welcome Daniel Thornton. And last but not least, we have Dr. Erin Eckert. She's an infectious disease epidemiologist and the director of infectious diseases at RTI International. So as promised, we have a set of very distinguished panelists to have a conversation about pandemic preparedness, not just here in the US, but around the world. And to open, I want to start with you, Dr. Olusoji. Tell us about some of the lessons that have been learned over the last year and a half with the pandemic. What are some of the lessons learned, some of the gaps that you've seen exist, both globally and regionally?
Thank you very much, Akudo, and I would like to thank Texas Biomed for convening this and the opportunity to join you and our distinguished panelists on this. We've learned a lot, and we continue to learn from this pandemic, which has gripped all of us. But to cut to the point, I think a very obvious lesson that we have learned is that as a world, we were definitely not prepared for this, for the occasion. Subsumed after that, or under that, is a realization that having a massive technological and scientific base does not necessarily guarantee an effective early response to the pandemic. And if you look at the 2020 experiences in the United States, and if you go across the pond, the United Kingdom, just take those two countries, which were ranked very highly on the Global Health Security Index before the pandemic struck, you saw there was a gap between the installed capability and the effectiveness of the response. And I posit that what we saw there was a massive deficit in leadership capacity at that time. You might call it executive ineptitude for short, just to be clear about it. Another lesson that we learned, and this is a painful lesson that the Global South learned, is that in times of peril, they're on their own. And you saw this manifest in the way commodities were hoarded, diagnostics, and then vaccines to start with. And we also realized that some of the norms of international civility broke down very early, such as erratic closure of borders, etc. There were also pockets of strong performance. Paradoxically, some of those did not come from where one typically would have expected. And I want to single out the Africa Centers for Disease Control and Prevention for this, because that has been one of the shining lights in this response to the pandemic, the Africa CDC. We've seen that global level constructs that are supposed to aggregate the interests of all nations and foster equity in access to technologies, be they diagnostics and vaccines, have put up very questionable performances. So the ACT Accelerator is the poster child for this, and the COVAX for vaccines is also a shining example of what can go wrong despite good intentions. And that's not the entire fault of COVAX per se. It was because the high-income countries initially hoarded vaccines, and in fact, they undermined COVAX. So one of the lessons we've learned as we go forward is that in order to be viable, an architecture of response, of preparedness and response to pandemics should not depend on a highly centralized construct. That's number one. It should not depend on the goodwill or the permission of the highly industrialized countries of the global north. That's number two. And what it should do is empower regional institutions and country leadership to take responsibility. So it's a distributed network. Finally, and then I'll turn this back to you, I think it's very clear that the extreme dependency of the global south on the global north is very unhealthy. Therefore, the leaders of low and middle income countries need to take more responsibility for health systems and pandemic preparedness and response in their own countries. And that means overhauling the current architecture of foreign aid. There is too much dependency of the global south on the global north, and they need to take more responsibility for their own affairs. Back to you, Akudo.
Thank you so much for all of those comments. Clearly, you're reconstructing the whole idea of global health institutions and really thinking outside the box. So you've brought out a lot. We'll come back to you with some follow-up questions. But first, I want to bring in Daniel Thornton. Daniel is with Gavi. We all know that Gavi is a major force for good in the global health architecture, mobilizing upwards of $19 billion for vaccines in the pandemic period. Daniel, I'd like to bring you in, and my question for you is, what lessons have you all learned? You're a big, powerful force, you've mobilized, and you did so successfully, but along the lines, what challenges did you face, particularly on the delivery end, as you made all these resources available to the world?
Thank you very much, Akudo. Thank you to Texas Biomed for organizing this and for inviting me, and greetings to folks in San Antonio and around the world who are listening. It's very good to be here. I think I'll start with a little bit of history, but just to note in passing that the pandemic is continuing around the world. I mean, we've seen 20 million people lose their lives, countless lives disrupted. The IMF estimates that the world economy will have lost $12.5 trillion by 2024, which is an extraordinary figure. And these figures are all rather abstract, but of course, the impact of the pandemic has been tangible for every one of us. In the global health world, we compare ourselves to the H1N1 flu pandemic in 2009 to 10. This was a smaller pandemic with around 500,000 deaths worldwide. But the course of that was really that rich countries immunized their own populations, and then lower income countries got donations of vaccines too little, too late to make a difference. This time around, we wanted to do things differently. As Dr. Soji has said, I wouldn't say that we've been 100% successful, but the aim was to allow global procurement of vaccines in order to ensure that they got equitably distributed, not rely solely on donations. And what we've seen in this pandemic is the fastest ever development and scale up of vaccines. In the past, the average time it took between a microbe being isolated and vaccine development was 48 years. And for COVID-19, the period between microbe isolation and vaccine development was less than a year. And the work of organizations like Texas Biomed is obviously vital for this kind of work, for both for this pandemic and for future ones. The average time between vaccine development and achieving 40% coverage around the world was 42 years in the past. And for COVID vaccines was achieved in 11 months. So, I mean, this is an extraordinary achievement for the world. But as Dr. Soji was saying, the vaccines have been unequally distributed. The organization I work for, COVAX, had a vision when it was set up at the start of the pandemic that 20% of the most vulnerable people would be protected wherever they lived. And if we'd succeeded in doing that, then many millions of lives would have been saved. Although we've succeeded in delivering more than 1 billion vaccines, we haven't achieved that equitable coverage. I think there are 3 reasons for this, and they're relevant to the lessons that you asked us to identify, Akudo. The first was COVAX was established although COVAX was established soon after the pandemic started, when world leaders met in June 2020 and started pledging funds. And we've raised, as you said, Akudo, 19 billion so far. This is unprecedented in a pandemic. But it wasn't enough, and it wasn't quick enough because wealthy countries had more money, and that money was available more quickly to lock in vaccine supplies. Secondly, wealthy countries and also China and India had vaccine development and production on their own territories. And until April 2021, India was allowing exports of vaccines, but the pandemic outbreak there stopped it. And so having domestic production has been vital to securing supplies in the early phase of the pandemic. And this has all meant that vaccines have really been available in a kind of income cascade, starting with high-income countries and working their way down. And low-income countries, many of them still don't have 10% coverage, which is way too low to protect their populations. And many elderly people and healthcare workers are not protected. So this brings me to the third set of reasons, which are about the challenges of running immunization programs in lower-income countries. The goal is vaccinations and not just vaccines, not just achieving equality of supply, but achieving equity in outcomes by raising coverage everywhere. And running very large immunization programs is challenging anywhere, and every country that has seen those challenges early on, but because vaccines are rightly highly regulated products, and they need to be stored at the right temperature and administered by trained workers. But things have been particularly tough for lower-income countries. Many of the vaccines haven't really been suitable for rollout in lower income countries in terms of the temperatures that you need to keep them at. Countries have lacked the resources to scale up quickly. And that's been one of the challenges. But really, we look to the future and we remain concerned that a major new variant could emerge. There's been a major new variant every 4 months since the pandemic started. There's no reason to think another one won't emerge. Just as Delta was worse than Alpha, there's no reason to think, the next one won't be worse. In wealthy countries, we have a wall of immunity which may protect us from that, but we need to carry on building that wall in lower income countries, which means maintaining steady supplies, potentially of new sorts of vaccines, and support to administer the vaccines. And then really thinking about the next pandemic, we need to do 3 things. And this next pandemic might be about the next variant of this virus or another pathogen. And as Dr. Soji said, infrastructure in Africa is vital, and continuing to build that infrastructure. But I think that there are three things that we need to do. We need better surveillance, so we know what's coming quickly, wherever it emerges. We need better manufacturing distribution around the world, so we don't rely on a few countries for vaccines, which inevitably are going to immunize their own populations first. And we need financing in place in advance of the pandemic so that we don't have that delay and we can secure vaccines as soon as we're aware of a deadly pathogen. And through that achieve better distribution of the vaccines and equitable distribution, regardless of income. Thanks very much. I look forward to the discussion.
Thank you very much, Daniel. We're hearing, there's some common themes coming out about vaccine equity, infrastructure in less developed countries, the sense that we're working really with a global village. I don't think that anything, the pandemic, I think beyond any other kind of world event, has really shown us how we are a global village and how, a virus that's springing in China or in South Africa could be here on a flight in a matter of hours. And so the idea that we have to operate equitably, I think, is something that's really coming out very strong from all our speakers in this symposium. And so thank you for highlighting that, Daniel and Soji. I do want to move on to Erin. Erin, in your world, you're doing a lot of community programming. You're working both in the US and globally. What are some of the challenges that you all have faced as you've tried to roll out communications or programming around infectious diseases? What are some of the barriers and some of the lessons you all have learned at RTI International?
Thank you, and thank you to the hosts of this interesting session. This, I think, is a great opportunity to have a dialogue about what we have learned over the past 2 years. My own remarks are based on my own experience in sort of two domains, both professionally through my work with RTI, where I am a malaria expert and focused on malaria programming primarily in Africa, and then through my personal experience during this pandemic, volunteering with the County Department of Health here where I live in Arlington, Virginia. And interestingly, and I think to your point, the lessons I have derived from those two very diverse scenes are almost the same, and that is the importance of investing in the community as a prevention mechanism for future pandemics. Firstly, to say a couple words about my experience working on malaria, I was at a conference last night, actually, in a different reception for World Malaria Day, where someone referred to malaria as the world's first pandemic. Now, I don't know how strong the claims are to being the first, but certainly evidence of Plasmodium falciparum has been found in Egyptian mummies, so we can safely say the malaria pandemic dates back, several thousand years. And here we are, and it's still one of the biggest killers of children globally right now. And vaccine, we spoke about how quickly the COVID vaccine came to be. Well, we've been working on a malaria vaccine for 50 years, and it was only last October that the first vaccine was licensed for use. So just to show you about the slow pace of science in some of these other domains and how amazingly fast the science around COVID has moved. But from malaria, because we didn't have a vaccine, but we do have effective drugs, the issue with malaria is first of all preventing, and second of all, diagnosing and treating children early in the course of the disease to avoid mortality. It's a disease that's easily treatable if caught early, but in many places, because of the resource issues that were discussed earlier, getting out to those communities is difficult. So particularly, I think, during the Ebola epidemic in West Africa several years ago, a lot of lessons were learned that we were able to leverage in this current pandemic. And those were that focusing on health facilities was not the most effective way of reaching people in many cases for malaria. During Ebola, people were afraid to come to health facilities, afraid to have contact with the health authorities for many reasons, which meant if we wanted to prevent malaria or treat cases of malaria, we had to reach out to the communities. We had to work with community health workers, teach them how to diagnose and treat the disease, teach them how to do advocacy and information giving around prevention, use of bed nets and other mechanisms that we have. And we actually pivoted many programs to really emphasize that aspect of what we were doing during Ebola and specifically in those countries. When COVID first happened, there was a lot of concern that we would be back where we were when Ebola broke out. But we learned those lessons well and moved forward, working very much at the community level, even throughout COVID, to continue to deliver the life-saving services of malaria prevention and control at the community level through community health workers, reaching out to those very remote communities. And we're by and large successful. Yes, there was an uptick of malaria cases during the pandemic for all the reasons you can imagine, but it was nowhere near what was estimated at the beginning. And I feel that was a success of this strategy of really continuing services through communities. Then quickly pivoting to my own personal experience, I volunteer with the Medical Reserve Corps, which is a national initiative started after 9/11 to train lay people or retired doctors, nurses, clinical folks on preparedness. And at the time, it was on preparedness for a potential bioterrorism attack. But when COVID hit, in my community and many other communities, we were able to pivot and use those trained volunteers as a response force for the COVID pandemic. As those of you working in the United States know, our public health system, if you can even call it that, has been neglected and underfunded for a very long time. So when COVID hit, those people responsible for delivering the services as they evolved really were under-resourced to do what they needed to do. And here in Arlington, Virginia, and many other communities, we were able to leverage a volunteer force of, in my community, over 1,000 people volunteering on a daily basis, taking on tasks like running testing centers, helping with the epi-analysis of the data coming in, helping do education programs, and then when vaccines came on, staffing the vaccine clinics around the county in a way that if it had been left just to the employees of the county, they would never have had the resources. So it took me back to what I learned from my work in malaria, that really working through the community and the people who are there and willing and ready to step up is the way to ensure that services get delivered and that people get the life-saving treatments that they need or prevention messages that they need to prevent outbreaks from becoming a future pandemic. So I'll stop there and happy to have a further discussion. Thank you.
Thank you so much, Erin, pointing out the importance of community and the value that we're all seeing in pivoting and making use of existing systems and applying that to a new challenge such as COVID. I think, Larry, you have a few things to say about pivoting. Coming from Texas Biomed. So why don't you tell us, we're in that preclinical space at Texas Biomed. Tell us about the infrastructure, the resources and assets of the Institute, some of the ways in which we did pivot during the start of the pandemic, and some of the challenges along the way and perhaps unexpected positive outcomes that we also experienced.
Thank you, Akudo. My pleasure to do so, and I'll do it succinctly. I'm a tuberculosis researcher. I've been in the field for 30 years, and so my career has enabled me to travel the world. So I wanted you to know from a personal perspective, my passion for what we're doing at Texas Biomed, and particularly growing it in the global arena, comes from my personal passion and understanding of the challenges that we face around the globe. When I talk about Texas Biomed, I'm going to tell you a story about a local institution with global impact. That's the way I'm going to talk about Texas Biomed. We are, just because I haven't been able to say this before, we are a freestanding nonprofit institute sitting on about 200 acres in a very nice section of San Antonio. We have about 400 employees at the institute. We are in the preclinical space, which is talked about less, but you would not have a shot in your arm without the preclinical development of any new diagnostic, therapeutic, or vaccine. That's the critical role we play. We have unparalleled resources for a private sector institute in a whole array of high containment, biocontainment facilities that allow us to handle some of the greatest infectious disease threats of humanity, and to do them safely. For example, we have the only privately owned biocontainment level 4 facility in the country. And our work on Ebola is long-standing, over 2 decades of work at our facility on Ebola. We have also one of the 7 national primate centers, and I'll tell you at the end here the importance of primates to get a shot in your arm. And then we have an interesting, I would say, hybrid structure in history, in that we've been working with outside agencies for decades, and we also have been working with regulatory agents like the FDA for decades. Texas Biomed has played a critical role in the cure for hepatitis C through our previous primate work related to hep C. In fact, one of our prior investigators were involved in the discovery of hepatitis C. We've been working with Regeneron for about 7 to 8 years, first in the arena of Ebola and bringing the vaccine to Africa through our preclinical work. And now, as you might have heard earlier, we did all the preclinical work on the monoclonal antibody cocktail for COVID-19. And I'll tell you this story about what a nonprofit can do for global health in just a moment. But actually, I think I'll tell you that now. I come from 34 years in academia, but let me tell you what a small nonprofit can do. We saw the tremendous challenge of COVID-19 in January, February of 2020. We don't have departments. We have programs. Think about them as Olympic circles that interface from the basic science, from the molecule to population health. When we smelled the problem of COVID-19, we pulled all our scientists in a room, not one department or another. We brought everybody in one room and said, how can we make a difference with this tremendous challenge we're about to face? And in one meeting, we decided our expertise was to bring animal models for COVID-19 forward so that we could work with industry partners to bring diagnostics, therapeutics, and vaccines forward. Okay? So then what did we do? Well, we talked to our marketing and development groups, and we put out an urgent call for help. We didn't want to wait to write grants. We wanted to move. So with 11,000 donors, within 7 to 10 days, we raised $5 million US. That means within 2 weeks, we launched our very first primate studies, uncanny. And in 2 months, we had fully established and validated the primate model for COVID-19. Now, around that time, we get a call from Pfizer. Said, you know, we've got this vaccine. It's this new technology called mRNA, and we've been working with BioNTech, and we cannot engage in clinical trials without a validated animal model, and we think that the primate model is the right model for COVID-19. Would you help us? So that was about April of 2020. And so we began doing preclinical studies in COVID-19. And what that means is that we had already grown up, sequenced and validated the virus, and we could challenge the animals with and without their vaccine. We learned by May or June, the country, the world didn't know, that we could almost completely eradicate COVID-19 by vaccination with the Pfizer vaccine. It was unbelievable data that is now published in Science magazine. So we were able, over the course of April, May through August, to do 7 studies to validate the vaccine. And that's when you heard about the phase 1, 2, and 3 clinical trials. That is precisely the speed and pace that a small nonprofit like Texas Biomed can bring to the global community, because as you know, This vaccine has been given to billions worldwide, but perhaps we need to do better by getting it distributed more quickly and more equitably. So I want to end by just making a comment about our challenge, however, and it's already been mentioned. David Bloom, his name was mentioned earlier in the conference, from the Harvard School of Public Health, published I think a very important paper in the Proceedings of the National Academy of Sciences in 2017. And it showed the classic historical curve of an infectious disease outbreak. And it's a bell-shaped curve, and it goes like this. First, people start getting sick. Okay. Then an article appears in the newspaper. There's something happening. Well, then people start saying, maybe we should start investigating this. So the next thing that happens is we decide we have a problem. Well, you know, only then do we start raising money. This has been raised before, has been mentioned before. That takes time to raise that money. The outbreak's already occurring. We've, in some respects, already lost tremendous ground. So then the money comes in, and there's a tremendous effort, and the COVID-19 effort is unparalleled. It's been amazing, as already been stated, 11 months to get a shot in your arm. But here's what the paper ends. Every time in history, when it's out of the papers, in 2 years henceforth on COVID-19, money shrivels up, and we have not learned the lesson of sustainability when it comes to infectious disease threats. I've mentioned it before, these threats are going to increase. We will experience another outbreak and another pandemic, particularly now because of that fragile public health infrastructure has been diverted to COVID-19, and there's now been an increasing number of cases of TB, HIV, malaria. You've heard this at the conference as well. So our gap in funding will grow, and so we need to change. And this is my ultimate passion. The reason why I have this Global Health Symposium is I believe that Texas Biomed will continue to engage in partnership models with government partners, philanthropic partners, our pharma partners, because we need a new structure. We need a new established network of people communicating to be able to take us from discovery to application faster and sustainable. And pretty much the remainder of my career is going to be focused on building those resources of sustainability and hoping that Texas Biomed plays a role in that. So those are my comments. Thank you.
Thank you very much, Larry. You know, you've said a lot. I'm going to come back and ask some questions in the next round. But first, I want to draw in Mayor Nirenberg. We're here in San Antonio. We're all, you know, here essentially hosted by you as mayor. I'm fairly new to the city and enjoying what I'm seeing, what I'm learning, the history. What I'm struck most by is the capacity and commitment to collaborate that I've seen in the city. I'm sure this played a great role for the city in the pandemic. So my question to you is, what happened in this city during the pandemic? What were some of the lessons learned? What were some of the unique collaborations that perhaps you had a hand in? And what were some of the challenges?
Sure. Well, thank you, Akudo, and thank you to our panelists and for Texas Biomed for having the symposium here today. We are certainly filled with pride in the work that Texas Biomed has done over the last few years to put us, I think, on the brink of saying that we are more resilient than we have been in the last 2 years with regard to what we will potentially face in further variants and other outbreaks of COVID-19. There's many lessons learned in the last 2 years with regard to our experience with COVID. And you said it first, and it's been emanated throughout the last half hour or so, is that the first lesson is cooperation and collaboration. There are so many different sectors and responses and layers of government that are involved when a crisis hits. Being able to work together, collaborate, exuding teamwork that needs to be exhibited even within the private community is vital, number one. And that's something that we try to reflect, as many folks in our community know. The judge and I were on every night during COVID-19 trying to, number one, give folks some consistent information, access to information from our public health folks, but also to just exhibit some teamwork that we knew was going to be important. And we've seen how disjointed our national response politically has been to COVID-19. You know, we've had many disagreements with our state government with regard to COVID-19 preventative measures, whether they're masks or vaccines, et cetera. But at the same time, you have to put some of those aside. If you can't win those battles, you have to work where you can together. And we did work with the state government and with the military and with federal government on making sure there were resources here to respond, to test folks, to vaccinate when we did have vaccines, et cetera. Another important lesson learned was that the currency, the tool, the most important tool to end COVID-19 or to respond to any crisis is public trust. And so it was very important for us as what we don't know about, or what we didn't know about COVID-19, we tried to be as transparent as possible, and especially for people in government and elected positions. You know, the tendency is to want to answer every question and respond to every need. In some cases, we didn't have the tools or the information available for us to do that. We had to be willing to admit that. We had to be willing to explain what we didn't know about what was happening and be clear about that. So, and perhaps the feeling is that that would create a little bit of anxiety in the community. I will tell you, the response in this community was that when they knew where our limit of knowledge or where our limitations were in the information that we had, or where they were understanding that we made a mistake and we were going to change the way we were going to approach something, when they heard that from us, the trust built, and we would be able to move on to the next thing together with some sense of trust and collaboration. Another lesson learned, a very important lesson learned, I would say, is that bureaucracy is the enemy of crisis response. And just as Larry said, as they got together without departments, all the scientists in a room to figure out what they needed to do in April of 2020, we were in a room in City Hall, myself, the city manager, Judge Wolf, and the county manager, and we put it all out on the table. We knew something was happening here that was going to be extremely disruptive, and we said, we've got to figure out what city and county government are going to do from now on. We knew what our standard operating protocol was pre-pandemic. It's going to change right now. And so we took a look at all of our resources and tried to get a sense of where we were as a community and what needs were starting to emanate. And that's when we decided, well, city and county government are getting in the business of feeding people, of making sure that people wouldn't lose the roof over their heads. It was basic needs starting at the very beginning of this pandemic that allowed us to pivot. And we wouldn't be able to do that had we not sort of almost on a moment's notice changed the way we operated at a city and a county government. I have to thank my colleagues who are here today. They pivoted along with us. Everybody had to change what we were doing. In fact, for a brief moment in time, and this might be amusing to some folks in here, there's always been a conversation about consolidation of government. For a brief moment in time during COVID, we actually consolidated government. We worked as one city-county consolidated government. The city council and the county commissioners court were working together in committees on different areas of basic needs, whether it's housing or food security, et cetera. But I think the most important thing we learned, Akudo, and something that I hope we won't forget because it's something that needs to continue as we move away from this phase of the pandemic, is that equity and social justice and the concerns about poverty were basic and foundational approaches to addressing the lack of resiliency in this country. You may all, and folks across this country, and maybe even across the world, when you close your eyes and you think about the early images of the pandemic, you will remember the photos taken of the sea of cars that were waiting to make their turn at the food bank. That was taken in San Antonio, Texas. And what that represented was a doubling of the food bank lines that we experienced a month or so prior to the pandemic beginning. 120,000 families in the week that the pandemic began were in our food bank lines to make food available to their children and their families. Think about that for a second. That was in April of 2020. That means in the 7th largest city in the United States, a place where we had roughly 3.5% unemployment. We had billion-dollar weeks of investment from private sector employers moving to San Antonio, creating jobs. We had the best economic momentum we have had in a lifetime. We had 60,000 families a week who were needing the food bank to put food on the table. That's the level of socioeconomic inequity that we experienced in a major American city. And we're not unique. Those cars represented the millions of American families across this country who were one crisis event away from financial and economic catastrophe. And so that's the lesson, I think, for the country, for our community, is that we have to address those issues of equity. It just so happens here in San Antonio, we have known that. We have had issues with generational poverty for a very long time. And for the last 5 years, my colleagues and I have recognized that and created an equity framework in the way we budget this city. Everything from how we're dealing with a comprehensive affordable housing plan to ensuring that we have a strategy around closing food deserts, things like that to address generational poverty issues. And I could talk for days about the significant public-supported investments that we are making in economic mobility, specifically adult workforce training, as well as early childhood education all the way through K through 12. We are working to create a sustainable economic workforce pipeline to break cycles of generational poverty. If there's a country in America that is committed to ending poverty, it is this city in San Antonio. I could talk for days about that, but what's important is that we are recognizing that the most disadvantaged members of our community, whether they live in San Antonio, Texas, or San Jose, California, the most disadvantaged members of our community are going to suffer the most when there's a crisis, particularly a public health crisis. And we can see that in our public health outcomes. So we also have to be committed to building up what Larry is talking about, which is a public health infrastructure. And we can make investments in our Metropolitan Health District department. We can make investments in partnerships with critical organizations like Texas Biomed and SWIRI, et cetera, and we're going to do that. But we also have to consider the very basics that families need: housing, gainful employment, access to post-secondary education, which is absolutely necessary if you want to live above the poverty line in this country. So those are fundamentals in terms of building resilience in our city, and that is the lesson that I hope we won't forget and that we remain committed to post-pandemic.
Thank you very much. Pointing out the importance of teamwork, the importance of social trust and trust in leadership. We had a keynote speaker, Judy Monroe, who is the president of the CDC Foundation. She talked to us yesterday about moving at the speed of trust. So I think this is what you're pointing out as well. And then cutting down the bureaucracy and focusing on what matters most. So thanks for sharing that. I do want to return to our first panelist, Dr. Soji. In preparation for this session, you mentioned on a prep call that there are some Sigma characters in pandemics around the world, and there's a relationship between the Sigma character and the institutions and the health systems behind them. Can you shed some light on that? We were talking about Dr. Fauci here and others. Tell us a little bit about what happens where there is a Sigma character and the response of the leadership and the health system to that character.
Thanks, Akudo. Let's pick up this thread. I think the central point is that success in preparing for and responding to a pandemic such as COVID-19 is heavily dependent on how robust the institutions are across the world, at the local level, at the national level, and at the regional level, especially. Concurrently, it is very helpful to have those two Sigma characters, as I call them, who are far from the median, leading the charge. And I think an exemplar of this that we have seen in this pandemic is my colleague, John Nkengasong, Dr. Nkengasong, who is the director of the Africa Centers for Disease Control. That is a kind of serious, determined, and credible leadership that is required when facing a serious problem, such as COVID-19. The capacity, the credibility, and the willingness to call a spade rather than engage in just euphemisms and platitudes. I think that is great. We've also seen at the national level, we've seen examples of highly effective political leaders. So, for example, take the Prime Minister of New Zealand, and she wasn't alone in this. That is not to say whatever they did was perfect, but it is to say they made a serious leadership effort that was very credible and made a positive difference. The flip side of the coin is you might also have Two Sigma character leadership figures on the deficit side. And as I pointed out, we had an example of that in the United States in the year 2020, and we had an example of it in the United Kingdom in the year 2020, which I refer to as executive ineptitude. So looking to the future, to come down very concretely in terms of what is needed, let me identify some things that need to be said and understood very clearly. My fellow panelist, Dr. Daniel, was clear that one of the limitations on vaccine coverage in low and middle income countries, many of them, not all of them, is the constraint on service delivery capacities there. That is absolutely true. The superior truth is that a fundamental reason for the vaccine deficit in those countries has been the hoarding of vaccines by countries of the global north. And the fact that many times when they were donating vaccines, they donated vaccines that were close to expiration, or the supply of vaccines was erratic, therefore making it difficult for those low and middle income countries to effectively plan for the deployment of their relatively modest service delivery capacities. Both of those are true at the same time. So as we go forward and we think, how does one make the best use of those emerging lessons? I think the next time around, the fate of the global south should not depend on the goodwill of governments in Europe and North America. It should not depend on donations of vaccines. And by the way, when African countries wanted to buy vaccines, quite a few rich countries in Europe and North America refused. They wanted to donate. Now, why would you want to donate to somebody who wants to buy? The reason is the power dynamic. When you are donating, you are in control. So the donation is at the instance of the donor. And that is part of the power imbalance. I would say a grotesque power imbalance, quite frankly, that needs to be redressed. But let me be clear. The responsibility for this does not lie on the countries of the global north. This is not a blame fest. The responsibility for rectifying this, in my judgment, rests with the governments and leaders of the global south. For too long, they have been too comfortable to be highly dependent on donations from the global north, on grant financing institutions bankrolled largely by the global north. And so they were somewhat surprised when COVID broke and the global north essentially said to them, "You are on your own." So they need to take responsibility. They need to be more accountable to their own people. And the locus of control, the locus of accountability needs to shift from the capital cities of the global north to the capital cities of the global south. That is crucial, and specifically, more manufacturing in the global south, more investments by and the global south in their own research and development, more public-private partnerships, more robust supply chains, and crucially, the kind of free trade agreements and tax breaks that will crowd in private sector investments. I think this is the way to go, or these are among the ways to go. More of the same will not do. Back to you, Akudo.
Thank you very much, Dr. Soji. Daniel, I'm going to turn to you because I think it flows, it's a good segue from what Dr. Soji said over to you, where you all are in a position where you're successfully mobilizing all these resources. You have the trust, right, in the international global health arena, and you are that sort of that basket that pulls in national, nation states funding and their commitments towards vaccines and to infectious diseases. How are you rethinking the partnerships with countries, with infectious disease institutes like Texas Biomed, with the private sector, in the context of now having to speed up and move at the speed of trust?
That's a great question. Thank you. I'm gonna spend a moment responding a bit to what Dr. Soji said, because I'm responsible for the dose donation program in COVAX. I'm fully aware of some of the challenges that he's identified. I think a few things on that. One is that we set up COVAX knowing that donations would not be sufficient, and that was clear from previous experience, because inevitably countries try and immunize their own populations first before they start donating. But secondly, some countries did start donating before they'd finished immunizing their own populations, and France and New Zealand are notable in that, some other countries as well. Ultimately, we cannot rely on donations. And although donations may continue to play an important role in giving us a wider portfolio than we can otherwise have and meeting the needs of lower income countries, we need to be in a different position next time. And partnerships is what it's all about, as you indicated, Akudo. One of the key partnerships that Gavi has is with an organization called CEPI, which was set up after the Ebola crisis. And CEPI exists to fund the development of vaccines for pandemic preparedness. And CEPI and Gavi are two sides of the same coin, which is getting vaccines ready quicker in pandemic situations. So CEPI works with institutes like Texas Biomed around the world to make sure that technology is in place, and researchers are collaborating, and the funding is there rapidly to bring forward vaccines. And then Gavi is there to raise the funds from donors and to make sure that there's a market there, so that the manufacturers scale up production and we achieve economies of scale, and we can get the vaccines quickly to lower income countries. So that's a key partnership for us. But I think we're not restricted to our partnership with CEPI. There's obviously scope for partnerships with other organizations, and we have representation on our board from the scientific and technical community around the world. And those are vital partnerships. I mean, Gavi was set up as an alliance of organizations working on immunization, recognizing that no organization can do this on its own. The world's too big. The immunization challenges are too great. We need lower income countries on our board. We need higher income countries, organizations with expertise, and so on.
Okay. Thank you so much, Daniel. Really, really good points you've laid out there. I'm going to ask you, Erin, if you could spend a minute, because we're heading towards the close of our session. But I do want to find out from you, again, sticking to the theme of trust. In the community there, you talked about various groups repurposing their mission to then focus rather quickly on COVID. What do you think it was that facilitated that? What were some of the things that you noticed with the volunteer groups that caused that ability to move very quickly and mobilize so that they could then work on COVID?
Well, that's a really interesting question. I think what comes to mind first, of course, is just goodwill. These are people that were volunteering in the public health space before COVID hit, doing various things. And I'm speaking both in the United States as well as internationally. We've had community health workers working on various things such as maternal child health issues in communities in Africa for decades. And then COVID came, and those were the individuals that the community respected. In most communities, the community health workers are selected by the community as respected individuals who live there, who've been there for a long time. People know who they are. And so when COVID hit, they recognized that they held a particular position in the community, and that this was the current most pressing need, was to do something about COVID. Early on, of course, that was just education and being able to inform people about what COVID was and how they could protect themselves with masks and distancing and what have you. Later, as other preventive mechanisms came available, as the science evolved, those folks just took it upon themselves to be the educators in their own communities, and then eventually to deliver services. When vaccines came online in many communities, those were the individuals that were helping to mobilize vaccination campaigns, as they've done for a long time for other vaccines or other types of services delivered. And the same is true in the United States. In my community, many of these volunteers are retired clinicians, doctors, nurses, epidemiologists like myself, who are looking for a way to give back. And COVID came, and we knew we had skills that were needed and stepped up. And I was particularly impressed at the level of response in my community, how many people wanted to pitch in and do something. It's a matter of identifying what skills people have and how they can be brought to bear. I really feel there's a room for everybody that wants to help out when something like this happens.
Thank you, Erin. So you're pointing out, again, going back to Larry's earlier point about pre-positioning. You're referring to specific communities where there had been significant investments in a public health infrastructure, be it in terms of the public health workforce or the systems and programs, and there was that pre-positioning already that was then pivoted towards COVID. So again, I think it applies. Larry, on to you. My question for you is, given that we have been so successful in our role in the COVID pandemic as an institute, what are your needs from government, from the private sector, from philanthropists, to make this even bigger and more impactful? What do you need as the CEO of Texas Biomed to bring even greater impact to the world?
What a setup for a CEO of a private nonprofit institute. Money. I mean, you need resources, technical resources, to finance the sustainable infrastructure is number one. But I think, in answering the question very briefly, I think we need to transform the way we develop diagnostics, therapies, and vaccines day in and day out to focus on this amazing problem of antimicrobial resistance. So we have people who are dying every day due to organisms for which we have no treatments any longer. We don't have a vaccine for HIV, malaria, or tuberculosis. These are very complex infectious diseases that kill millions each year around the world. I think we can develop an engine in a partnership model. It takes time, and it builds you have to build trust with our technical expertise and our partners. You've already heard, with Gavi and SEPI, that we can develop a more robust engine, infrastructure engine, to enable us to be ready. If we have the technology online and we're building structures that really produce on an annual basis diagnostics, therapies, and vaccines, then when somebody gets sick, then we can more effectively pivot, which is my word, and move quickly to solutions, which I think we must do because these challenges will grow.
Okay, thanks. Another running theme, I think, of the symposium has been breaking down the silos, creating that continuum so that a Gavi is hearing from nonprofits like Soji's and is partnering with the institutes that are developing the therapeutics as well as the preventatives like Texas Biomed. And so we need to break down the traditional structures of all being in silos and get together around the same table and deliver together. So I think that's your point. Is closer,
well before next
well
finish.
Before. Okay, so thank you for that. I do want to make sure we take one question. We're fast coming to the close. Mayor Nirenberg, What is one thing that you want to share that perhaps you would do differently? Perhaps that, was a lesson learned that makes you say, okay, the next pandemic, this should change, before we take one question from the audience.
Wow. That's a tough one. Well, let me go where my mind immediately goes to when you ask that question. I think one thing that we did not do, and frankly we have not done yet, and that is to prepare the public for the transitions that happen in the course of a pandemic. That is that we have so politicized the pandemic in this country and maybe across the globe, that you can see folks throughout our community, through every community, who are devoted to the public health guidance and have operated in a way that when the pandemic struck and we did not have any tools other than the most draconian social distancing and shutdown types of policies, that was our only way of dealing with an infectious disease that we really had no data and science to guide us with. And there are many folks, I think, that are still in that area because they see everything on the other side as totally dismissive about the impacts of the pandemic. We have to work with our communities to expect transitions in the way we handle infectious diseases, particularly new ones. That there is going to be a phase where if we don't have any tools, we're going to have to be working together as a community in some really difficult ways. But as we gain more knowledge, as we gain more understanding, as we have more science and we have more tools available to us, we're going to pivot our response. And I don't think we have been very clear with the public on how we do that. And you can even see it today as the CDC issues changes nuanced language in their mask guidelines, that there's a really abrupt and political response to that when it's a natural course in the evolution of dealing with what has become the COVID-19 pandemic.
Thank you. You've highlighted something that I think is not easily apparent, and that's a really good lesson learned. Thank you. I want to take one question from the audience. Any takers? Okay. Well, it must have been a very, very clear panel. So without further ado, I want to thank all of my distinguished panelists today, Dr. Olusoji Adeyi, Erin Eckert, Daniel Thornton, Dr. Schlesinger, and Mayor Ron Nirenberg for joining us. Thank you for giving us your time, your insights. We appreciate you, and please join me in giving them a round of applause.